and welcome to Pharmacy Videos. My name is Dr. Raman Faruqi and I'm a pharmacist here in the UK. I practice in hospital pharmacy as a clinical pharmacist and I have experience of leading clinical pharmacy service on the ward level. So today's video is about what actually we do as pharmacists on the wards. General concept is pharmacists go on the wards and check medication related interactions with patients, and that's it. And possibly in addition to that, supplying medication. So I just wanted to cover superficially what sort of work that we do on the ward level, and then in my later video you will see some sort of interactions, and I'll share my interaction experience with you guys. To start with, pharmacists are involved in medicine reconciliation, which means we take drug history from patients and double check with them what medication they're taking. We reconcile them, ensure that we prescribe the medication the way they're taking. For example, if it's prescribed 3 times a day, the patient says no, they're actually taking once a day, but prescribed in the way the patient takes it. Okay. In addition to if there's any other drug that they're taking which is not documented, not in the GP record, they're buying over the counter any supplements, any herbal medications, or anything that so we need to know everything about it really. Any eye drops, ear drops, nasal sprays, ointment creams. Sometimes they think, you know what, it's not important, but this is what our job is, to make sure that we ask all these questions to ensure that we know everything about what they actually take. In addition to that, we also make sure that we know their smoking habits, we also know their alcohol drinking habits, and other things as well, if they do any other thing, for example, illicit drugs, if they're users of those drugs, and that would obviously contribute in the metabolism of drugs that they'll be taking. And particularly when they're staying in hospital, for example, if they're a smoker, make sure that we supply nicotine replacement therapies for them, and it's all charted when they're in hospital stay to ensure that they are adequately receiving nicotine, and depending on the usage of the cigarettes that they do consume on a daily basis. So all these things obviously make part of it, and as pharmacists we need to know what comorbidity they have, what other medical condition they have, what's past medical history like, what their social history like, what may have contributed to them. And also in addition to that, obviously the medication history and the medication doesn't actually tell you if they take it, so basically questioning the patient and making sure that we take the proper drug history. Okay. In addition to that, obviously we also ensure that anything new prescribed in the hospital while they're staying here is appropriate for them. Obviously, again, comparing that to the comorbidity, seeing if the indication is right, the dose is right, it's for the right patient, patient's weight is correct, and constant monitoring of those, in addition to checking the bloods, checking INR, checking LFTs, whatever, renal function, ECGs, blood pressure, heart rate, everything. To ensure that we actually prescribe what's prescribed for them is appropriate for them, basically. So de-prescribing, for example, something's prescribed, patients admitted with, and there are medications that's prescribed for them, and it's not appropriate anymore, so ensure that they're de-prescribed. For example, if the patients come with an opioid for analgesia, and they're prescribed some laxatives, and then for some reason doctor suggested, or the clinical team go around thinks, you know what, his pain is okay and he's not requesting for when required pain relief, then we need to also discontinue the laxative that's associated with that. In addition to, if you talk about PPI addition, with dual antiplatelets in some patients, so you stop one of the antiplatelet but obviously not stop the PPI, which wasn't required. So these sort of things obviously pharmacists need to keep an eye on. Interactions really important, especially those cytochrome P450 inhibitors, inducers, especially to know if the patient is a smoker, that would obviously induce a metabolism. So we need to know the history, and obviously to ensure that we check the levels and do the therapeutic, neurotherapeutic index drugs, which our patients prescribe, to make sure that if you're required to monitor the levels, we do it properly. Okay. Others are administration related. For example, if nurses are administering something and they're unsure about, for example, if there's a fluid overload, and if the patient's a diabetes, obviously we can't give them more fluid, so giving them medication related advice on what actually we can give, what's alternative available for them. If someone's hypertensive, if someone has diabetes, and what sort of we can suggest for them is best for infusions, and to ensure that we review the antimicrobials to ensure that they are reviewed on time, and to make sure that checking the inflammatory markers, if they are raised, and when do they need to move from IV to oral. It's best to be, move to oral. All those of these queries, obviously, in addition to the mention about basically monitoring them constantly. So it's not just about seeing patients, it's about monitoring the constant progress on a daily basis to see if they prescribe something new, what the blood's like, how they're performing on how they're taking on the treatment, and obviously going through the side effects, see if there's a complaint about something really. So it's all about communication, talking to the patient, talking to the clinician, and be part of the multidisciplinary team. In addition to that, obviously, if the patient is going home, they're discharged, pharmacists are involved in clinical verification of discharge to ensure they document everything. It's all about non-verbal communication. Tell the GP what medication that we have stopped during inpatient stay, what is started acutely. If their potassium is low, they've started on Sandoke for 3 days, then GP, if they can kindly monitor the levels, UNEs, and monitor those things. So all these things, obviously, needs to be documented and clearly written, so they understand that what was the journey when they were admitted, what was stopped, what's switched, what's been replaced. For example, if clopidogrel is prescribed and it interacts with omeprazole, so we switch the PPI from omeprazole to lansoprazole if it doesn't interact. So all these things obviously needs to be communicated, otherwise it'll be very confusing and the GP will be ringing the hospital to see what sort of changes that we have made and why. In addition to that, obviously, there are other things, there are a list of things that the pharmacist can be involved. For example, if there's something not suitable prescribed by the prescriber, then have a discussion with the prescriber to see if he can suggest an alternative. For example, if you're monitoring ECG, see if the PR is prolonged, then obviously we're holding beta blockers. If 2 or more drugs are causing the acute interval prolongation, we notify them to clinician to see if it's appropriate for them to be able to continue on those. And all those things. The list goes on and on and on. We can't actually describe the job of pharmacists in a 5-10 minute clip anyway. So in the next few videos in future, I'm going to be uploading some of the real interventions. It's very difficult for us to be able to upload it from hospital because we have data confidentiality, and we have to obviously appreciate that and to ensure that we keep the Confidentiality Act intact. So I'll catch up with you in the next video, and thanks for watching this video, and we'll share some more evidence-based clinical interventions, and I'll share with you. Thank you very much for watching this video, and I'll see you very soon. Bye.